Hi everyone, welcome. My name is Zoe and I'm a research manager at the Follicular Lymphoma Foundation. Welcome to today's webinar. It's brilliant to see a great turnout yet again. And if you haven't already, we encourage you to follow the link in the chat to watch previous webinars. We've got another series coming up soon, starting in September, and they happen generally every other month. We have a bonus one coming up in August, so we will share details about that at the end of today's webinar. A couple of things, housekeeping things from me, and then I will hand over to Mitch. Today's webinar is being recorded, and we plan to upload the whole final video on our website, where only the speakers will be visible, so comments will not be visible in that video. Thank you to all of those who have submitted questions at registration. We'll cover as many as we can today and save others for future communications. Please do ask questions in the chat area, and we will try to cover as many as we can. They can be made anonymous if you like. And finally, as I can see some of you are already doing, it'll be great if you feel comfortable to share in the chat how you affected, if you're a patient or a loved one or healthcare provider or something else, and which country or region you're joining from. So that's all from me. Over to you, Mitch.
Thanks, Zoe, and welcome everyone to our program today. So we've had a series of educational webinars which are available on our website for you to look at your leisure. Today the purpose is to review some of the latest findings which came out primarily at the recent International Conference for Malignant Lymphoma, or ICML. It's held every 2 years in Lugano, Switzerland. It's a major lymphoma meeting, really brings together top leaders globally. We were excited to see some of the findings. We also held an FLF symposium at the meeting on where we are in the path to cure. This follows up on a symposium we held there 2 years ago. We're really here today to talk about what's come out of the meeting and where we are on this path to cure FL, which is really one of the key pillars of the FLF. We do put follicular lymphoma front and center. That was our role at the conference. We also want to ensure that the patient voice is heard. And so today we have an expert and a patient to discuss these findings. The satellite symposium we thought was very productive, had a great turnout, great discussion, really moving the field forward. So today we're going to hear a little bit about what it means to have a cure and different definitions of a cure or functional cure. We'll hear from our patient advocate, Paul Mollet, who actually had a very moving video there on what it would mean to have a cure, and some highlights from Dr. Jessica Okosin, who is been with us before and spoke at the meeting, our satellite, as well as at the meeting itself. So please do participate in the polls as we go through this. There's only a couple, but we do find these very useful, and you give us your feedback, and we learn about what we can do in the future. As I said, ask your questions. We may not answer them directly, but we'll try to cover them in the discussion. You'll see the first poll up there while we continue talking. And what does a cure mean to you? Is it complete eradication, long-term remission without need of treatment? Is it manageable with minimal impact on your life? Or, gee, I don't know what it is. Or we don't think it's curable, because that's what you probably heard from your doctors. So let us know what you think. While we're doing that, I want to introduce our panelists. I'm going to turn first to Dr. Jessica Okosin. Jessica, you want to tell us about yourself and why you're here?
Thanks very much, Mitch. It's great to be here. So as Mitch already mentioned, I'm Jessica Okosin, and I'm a hematologist in London in the UK, but I also lead a research lab where we do a lot of research on the biology of follicular lymphoma, and I've been a scientific advisor to the FLF since its inception.
Great, thanks. And Paul, maybe tell us a little bit about yourself, and then we can go into your story a little bit.
Sure, thank you, Mitch. Yeah, hi everyone. I'm Paul. I was diagnosed in 2017. I'm currently living in Spain from the UK, and I'm one of the super supporters on the Facebook group linked with the Follicular Lymphoma Foundation. And I'm just really looking to be part of the journey towards a cure by advocating really for people like me. Hence why I'm here today. Thank you for inviting me.
Thanks. So, one of the things that came across in your video, I think we could start with what a cure would mean. It's one thing to say, hey, I'm in remission, I'm doing okay. But what would a cure mean for you in your day-to-day life and your ability to plan those sorts of things?
I mean, just looking at the options there on the poll that you just put up, I mean, really, a cure for me is complete eradication of disease. It's no longer incurable, as we are told by our doctors frequently. I think for me, remission with no need for treatment would be great, but really, a cure for me is complete eradication because the implications otherwise are not being able to plan for the future. Really a daily anxiety of living with the uncertainty of this disease. Yeah.
Yeah. So I think that's a key is it's not only do we have to cure it, we have to be able to tell you that, it's gone, and which is another step. Right. So Jessica, we're hearing more and more in related diseases, the term functional cure. So I wonder if you just mentioned, so what's your idea of cure and what a functional cure might be? Because some people think we've achieved that for many patients with FL and don't worry so much about cure. So maybe you can take a minute to talk about that.
Yeah, thanks very much, Mitch. So, I mean, as Paul already alluded to, I mean, what our patients really want is complete eradication of their lymphoma. So not requiring any more treatment forever, not expecting the lymphoma to come back. So that's, I suppose, the true definition of a cure. But I think what we're recognizing now, having looked after many of our patients, some of our patients for decades, is that there is this sort of concept of what we call a functional cure, which is ability to kind of keep the lymphoma under control to the point where it isn't causing any harm or any symptoms. I think the way I sort of explain it to my patients is that it's like putting the lymphoma to sleep, and even though there may be small amounts of the lymphoma still left behind, it's not active, it's not dangerous. And in principle, my patients should be able to live their normal lives. We don't expect the lymphoma to reawaken. Now, the challenge that I have is I want to be able to tell them that they're functionally cured 10 years. But I don't want to be able to wait for 10, 15 years. So the challenge we have now is that the only way I know that a patient is functionally cured is because I've been looking after them in clinic for a decade and their cancer hasn't reawakened or the lymphoma hasn't come back. So I think that's a challenge. I think many of our patients are functionally cured in the sense that the lymphoma isn't going to come back. But the challenge we have is how do we identify who those patients are? And can we tell them with enough time so they don't have the anxiety that Paul talks about? And I recognize as very one of my patients, they get really nervous when they come to their clinic appointment because they don't know what I'm going to say, whether their lymphoma has returned or it hasn't. And being able to predict this would be really, I think, a real sort of important game changer, life changer for our patients with follicular lymphoma.
Great, thank you. Yeah, I think the results of the poll, about 40% of the people did say they want that complete eradication. I think that's sort of our goal in the FLF. But just having it under control for long term would be okay for about a third of patients. And so I think there's a mix, but I think the idea is really to be able to predict or tell the patient you're in that long term good group, and that's what we don't always not able to do. But obviously there's an excitement. There's a lot of new drugs over the last 5-6 years in follicular lymphoma, and then primarily in the relapse setting. So Jessica, maybe you could tell us, we've had immunotherapy with rituximab, an antibody that binds to B cells for over 25 years, but now we're getting to harness the immune system even better. So I'm wondering if you tell us a little bit about where we are with immunotherapy, particularly the T cell use.
Yeah, thanks, Mitch. I mean, when I think about it, I always I have this slide that I always use to really show the progress of treatment in follicular lymphoma. And as you say, rituximab was approved about 25 years ago. And I think what's been really for me very heartening to see is that in the last 5 to 6 years, the number of new therapies, new treatments for patients with follicular lymphoma has really kind of exponentially increased. And a large group of those treatments are what are called sort of bispecific antibodies, or what are called T-cell engagers. So many of the new therapies that have been approved, like CAR T-cells, are essentially drugs that help harness the immune system. So try to use the patient's immune system to try and fight the lymphoma. So T-cell engagers are basically a type of lymphoma treatment that helps the body's immune system find and kill the lymphoma cells. And the way I kind of, the analogy I use to describe it to my patients is, if you think of your T cells are basically, like special immune cells, and their job is to try and fight off things that don't belong in the body, like your lymphoma, like viruses, for example. But the lymphomas are very good at hiding away. So I think of like the T cells, like your police officers or your soldiers that are meant to be patrolling and trying to basically look for the lymphoma cells. But the lymphoma cells are very clever. So they're basically like a criminal hiding in a crowd. And so the T cell doesn't know how to find them and arrest them. So the T-cell engager basically acts like a guide dog, right? So a guide dog that can sniff out and grab the police officer, and then with one hand grab the police officer, and with the second hand point to the criminal, the lymphoma cell. So it's kind of bringing the police officer, the T-cells, and the lymphoma together. And that's exactly what T-cell engagers, so we call them bispecific. So bi because it's got two arms, one arm for bringing the T-cells in, and the other arm for bringing the lymphoma in. And so these T-cell engagers or bispecifics have really been demonstrated to be very effective in follicular lymphoma. So over the last 3 to 4 years, there have been 4 or 5 different bispecific antibodies that have been available in clinical trials, but also a number of them have been approved in a number of countries around the world. And I think what's been really impressive, most of these bispecific antibodies have, as you say, been used in patients where their lymphomas, their follicular lymphoma has returned. So what we call relapsed refractory follicular lymphoma. And they seem to be very effective. Probably about 80% of patients will respond to bispecific antibodies. So this is as monotherapy. This is at the drug on its own. And patients can get a complete remission in probably about 60 to 70% of patients. So I think it's really a very effective therapy. And comparing that to CAR T cells, which is a different type of immunotherapy that we've heard about, this is a little bit different because basically you have to take the patient's T cells out, and then you have to take them to a factory, and you've got to manufacture them. You've got to basically supercharge these T cells so they can recognize the follicular lymphoma cells when you put them back into the patient. They're a little bit different in the sense that the bispecifics are what I call, they have broader access because they're off the shelf. So you don't have to manufacture it. It should be in most pharmacists, they should be available in the hospital for the patients to use if they're approved in the country, whereas CAR T cells need to be manufactured. They're both very efficacious. So we saw a lot of data in Lugano on the bispecific antibodies. There is now longer follow-up data that shows that actually that patients that have these therapies, for a proportion of them, they're still staying in remission after a period of time. So I think that's hugely reassuring for our patients and the community in general, because it increases the options that we have in the setting of the relapse refractory follicular lymphoma.
Yeah, thanks. That's a great discussion, and I think some of the patients who were treated on those single agent trials, maybe after they had 2 or 3 earlier types of treatment, not exactly running out of treatment, but treatments weren't going to work so well. And this really seems to be working much better than any other option. So it's really changed the field in that setting. So where are we going with those? I mean, I think 2 of the areas that we might think about are, gee, they're good, but they're not perfect. So should we combine them with something?
Yeah.
Or can we use them earlier in the course before the patients had chemotherapy? So can you tell us where we are with those 2 questions?
Yeah, I mean, it's great that you brought that up, Mitch, because the field is doing exactly those 2 things. So one of the things that we've seen already when it's used on its own, so what we call monotherapy. So and most patients, even though 60%, 70% of them get a complete response, we do know that some patients in time, their disease will come back. So it probably gives what we call a median PFS, or median progression-free survival, of probably about 2 to 3 years. And that's better. I know that may still sound low, but that's better than the therapies we had before, which were maybe giving about a year disease-free period. So we need to do better than that. We need to push that out to longer than 2 to 3 years. And so we're starting to see combination therapy. So this was some of this was presented in Lugano, but also ASH last year, where they're combining the bispecific antibodies with other therapies like lenalidomide, for example. There is some really early data that suggests that this combination actually may give CAR T cells a bit of a run for their money. They're probably as effective, maybe even more effective than CAR T cell therapy on its own. So I think that that's a space that we're going to watch. There are a number of clinical trials evaluating it. So that's inpatient combination therapies in the relapsed refractory time point. As you mentioned, what we really want to do is to give patients the longest disease-free period as possible. So to do that, we want to make sure that we're giving the patients the best therapies first. And so that's why there's a lot of, impetus to bring or to move bispecific therapies to the initial treatment setting. And so there are about 4 or 5 clinical trials at the moment that are ongoing, which is looking at bispecific antibodies in combination with either on its own or in combination with other therapies, and they're comparing them. So these are phase 3 trials where you're looking at the 2 arms of the trial. One is the experimental arm, looking at the bispecific antibodies versus or against, comparing them against the standard conventional therapy of chemotherapy and immunotherapy like rituximab. So we really await the results of these phase 3 trials, because I think, we may, if we're having this conversation in 5-6 years' time, the standard of treatment for follicular lymphoma initial therapy may be quite different. We may not see rituximab anymore in the first line, and we may not see chemotherapy anymore potentially because of how effective the bispecific antibodies are. I do want to sort of a point of caution as well that, sometimes when we have lots of shiny new toys, we also have to think about long-term, side effects as well, things that we have to keep very close eye on, side effects and toxicities. And this is where quality of life, I think, is also really important. It's not just about getting the most effective therapy, but how do we get a therapy that we can maximize in terms of being effective, but it's also got to make sure that it maintains the quality of life for our patients. So I think those combination of things are very important to consider.
Mm.
Yeah, excellent point there. So Paul, if your doctor's talking to you about what you might get for the next treatment if your disease ever, started to activate, as physicians, we often spend a lot of time on how long does the disease stay away, called progression-free survival time before the disease starts to go back. But what factors are you going to ask your doctor and say, hey, what does this mean for my day-to-day life? How does it interact? Whatever. So you can tell us a little bit what your thought process might be in considering your next treatment.
Sure. I mean, there's a bit of important context behind this in that I've just been declared in remission, which is great news. I was watch and wait for 7 years. I completed 2 months ago now bendamustine and rituximab first line. So, great news. I wish I could have avoided chemo at the beginning. And I know if I was living still in the UK and I had private insurance, I could have gone for, I think it was lenalidomide and another, maybe a bispecific, if I remember. And that would have been avoiding chemo altogether. So for my next line of treatment, I would hope to avoid chemo. And I know that in Spain, R-CHOP was recommended, and I pushed quite hard against that because I'm thinking, I'm relatively young, I'm 43, I'm fit and healthy, I like to exercise a lot. And for me, quality of life is probably the most important thing. So if I'm trying a new drug, I might be very excited about it, but if I know that it's going to cause me heart problems in the future, or I'm not going to be able to exercise and be as active and healthy as I usually am, my mental health is going to suffer. Fundamentally. So I would love a doctor to tell me this will give you 5 years of healthy, a blood test maybe, something that they can provide me with that tells me I have this amount of time to go away and forget about it. I don't know how close we are to that, but I would love other options other than chemotherapy. And I'm excited because this is a slow-growing cancer for most of us. that there may be other opportunities when I next need treatment, hopefully not for a long time.
Right. Let's hope not for long. And it does bring up, right, I mean, this idea that if I'm going to have multiple treatments over my lifespan, you know, there's anxiety about how do I choose what's best now? And, you know, so as Jessica mentioned, you know, these are new tools, and, you know, maybe we don't have people treated with a bispecific 10 years out yet. And what sometimes is unexpected things. So it's always a balance between what we know, what we think we know, and then real life. So these are discussions that they'd be complicated for you and the doctor, because we're making the best decision we can based on what we know today, and that may change. It also brings up the question about accessibility, right? You would have gotten different treatment in Spain than in the UK, and certainly in the US, there's other things available. So where you are does factor into that.
Right, and I also lived in the US for a couple of years, so you know, I've been in those three countries, and the I guess the standard of care or the access is very different. I've noticed. So I would certainly have done R-CHOP here if I hadn't pushed and got a second opinion or third opinion even.
Yeah, I think that's an important point. Is also getting additional opinions. Usually with this disease, you do have time to explore your options and see. And because there isn't a one right answer for everyone, it is important to get some information and figure out what's best for you at your stage in life, in your situation, et cetera.
Right.
So Jessica, what you know, so we're moving these things up forward. Are there new things on the horizon? I think there's another antibody that got approved recently. Maybe you could tell us a little bit about that and what kind of data is required to get a new drug approved and out there.
Yeah, I mean, Mitch, absolutely. I mean, we heard, I think, whilst we were in the Congress, that this combination of drugs, well, one of the drugs is called tafasitamab. So it's a monoclonal antibody, so another type of immunotherapy, but it targets a different protein. So rituximab, we talk about it as being targeting something called CD20, which is a type of protein on the surface of the lymphoma cells. CD19 is another protein which is also present on the lymphoma cells, and this tafasitamab specifically targets that. And in the meeting, they presented the results of the clinical trial that looks at this combination of tafasitamab with rituximab and lenalidomide. So some of us will be familiar with rituximab and lenalidomide because this is approved in the second line setting and beyond. And in this trial, what they did was they looked at this addition of tafasitamab with R-squared or rituximab lenalidomide that was compared against rituximab lenalidomide on its own. And in this trial, so this was a randomized phase 3 trial, lots of, I think it was probably about sort of 600-700 patients. And they showed that actually the combination, what we call the triplet, 3 different drugs, was better than the 2 drugs of rituximab and lenalidomide, and increasing the kind of disease period by about 8 to 9 months. So again, it's a, you know, slow. It's obviously not a drastic improvement, but I think it's a significant one, and that can be quite important for some patients. So giving people a disease-free period of about 22 to 23 months compared to rituximab and lenalidomide, the sort of dual combination. So this was FDA approved. So what that means is that that's approved in the US. It doesn't mean it's available in all regions yet, but I suspect that we may see this combination being available. It's FDA approved in the setting of when the lymphoma, the follicular lymphoma, comes back. So I think it's an important therapy option for patients, because of course there are some regions of the world that don't have access to bispecific therapies or CAR T-cell therapy. So having another combination in the armory, I think, would be really important. I think, again, this speaks to when we, you know, get excited with new therapies. I'm maybe a bit more of a pragmatist. I also think very carefully about, you know, balancing, you know, quality of life. Although this therapy combination is very effective, but we also know that it does require a lot more hospital visits. So patients do have to come in weekly for these infusions for the first sort of 3 months. So there's an element of that is a little bit different in terms of how the treatment is delivered. And that's something that patients may want to consider and discuss that with their physicians when that combination becomes available. So I think it's exciting to have new combinations, particularly, and as you said, Mitch, I think it's really important to say that sometimes it's very individualized. I think that, as a hematologist, I'm constantly balancing, thinking about an individual's, quality of life, what their preference is, that there are many things to think about for the individual. So one combination may work really well for one patient, but may not work so well for another. So I think that's important to say. So if we can have as many options as possible, that it means that we have a lot of, things to think about for individual patients.
So one of the questions in the chat sort of had to do with, sort of how do we predict who might respond, who doesn't respond, why people don't respond, why their disease is resistant or comes back after these new immunotherapies. Simple question is, obviously, is the target, if you have an antibody to CD20, does it go away? Or if you have a CAR T directed to CD19, does the cell learn how to get rid of CD19, which has implications for sequencing, but in the order you do treatments? What are we learning about? Are we in a place where we might be able to predict who might do better with one treatment or another, or at least why people are the disease is or becomes resistant? Are we making any headway in those areas?
Mitch, you raised a really important point. I think we're getting to the point where, as we have more options, we have to get better in the way we select these options for our patients. And I think to do that, we need a little bit more tools to help us to do that. And I think that's the field is galvanized to try and sort of identify what we call biomarkers. So these are essentially tests that we can do to try and tell us, try and give us a little bit of a, early information about whether a patient will respond to a therapy or if they won't. And I think that we're not quite there yet. I think we are trying to do this for a number of the different treatments. So, for whether it's bispecifics or CAR T, I think something that we're probably starting to get a little better at is, once patients are on therapies, being able to see how good the therapy is at eradicating most of their lymphoma. So what we call measuring a minimal residual disease, or MRD. So we're starting to develop some tools or assays, tests that we can use to basically identify whether there are any follicular lymphoma cells that are left behind. And this is done in a number of different ways. The kind of conventional way is normally a scan, isn't it? A PET scan. So you have your treatment, then you have a PET scan, and the scan will tell you whether there's any of the lymphoma left behind. But it's still a blunt instrument, right? So you have to have a relatively large amount of the lymphoma left for you to be able to detect that. And so I have tools or tests that can actually be even more accurate than the PET scans. And this is where we're starting to look at these, what I call blood-based tests. So things are circulating to, tumor DNA. This is basically what they call liquid biopsies, where you take a patient's blood sample and you use very sensitive tests to measure how much of the lymphoma is left behind. So these are still research tools at the moment, but these are being evaluated and tested in many clinical trials in with patients with follicular lymphoma treated with a number of different therapies. And I suspect that in the not too distant future, this sort of test will become available to allow us to tell how well a patient has responded to their therapy. We still are a little bit far away for telling patients upfront. So what I would like to have in my toolbox is, for me to be able to guide me to select which patient goes best with which therapy, or which therapy I think will work best for them. I would love to have some tests to tell me that, but we're not quite there yet. And I think it requires us to study many patients on clinical trials, and being able to, many patients, thankfully, very altruistically consent for samples to be studied on clinical trials. And by doing that, I think we'll be better informed in the coming years about these sorts of tests.
Yeah, I think these liquid biopsies, or just the MRD, minimal residual disease tests, hold a lot of promise, at least to be able to tell a patient, oh, you're such a low level, we can't tell you for sure you're cured, but it's going to stay away for a long time at least. That would release some of the anxiety. So I guess one of the questions I have is whether, are we just randomly getting rid of the lymphoma cells, or is there a specific set that is that residual and are going to cause problems? And I know your work has worked, you've been a pioneer in CPCs, clonal progenitor cells, and are these the source of relapse? And if we could identify and attack those, that might get us over the edge. Was there anything at the meeting or coming up where, with that, I know we discussed it a little bit at the symposium.
Yeah, no, I think, Mitch, absolutely. So some of the work that not just our lab, but actually a number of others around the world that have found is that, by studying patients' follicular lymphoma and over a period of time, we've been able to, as you say, identify that what's probably happening is that our current therapies are great at eradicating the bulk of the follicular lymphoma, but it's probably leaving behind a few morsels of the follicular lymphoma. And that those, that small population of cells that we call that we sort of coined this term, the CPC, are probably hiding away somewhere. And then several years later, they reemerge and expand out again. Now, we think that this may be the kind of, could that be the Achilles heel? Like if we can find a way to target and eradicate that little morsel that's left behind, does that reduce or completely eliminate the risk of the follicular lymphoma coming back? So this is a huge area of research at the moment for my lab, but also many labs around the world, where we're trying to understand, well, what are the features? What are the features of these cells? And what makes them so unique that they can hang around and hide away from the therapies that we give to our patients? And I think that we're making progress there. I think we're getting a better idea and understanding of these populations and how we could in time target them. And this is being done in a number of ways. So obviously, in the symposium, Ari Melnick talked about some of the, looking at the different, like almost the different features of the lymphoma. So, every patient's lymphoma has probably got 60, 70 different mutations. So these are changes that are abnormal, right? So genetic changes that are abnormal. And what Ari Melnick is doing is basically trying to look at some of these genetic changes to understand what does that genetic change do? How does that change lead to the lymphoma developing? Because if you can understand how it developed in the first place, then you can think about how you can reverse it or target it. And we know that within the CPC, or this leftover morsel, that they have certain number of these genetic changes. So if we can basically target some of these genetic changes, if you first of all understand what do those genetic changes do, then we can try and see if we can use that as the Achilles heel of these cells and then target them. So that's kind of where the field is sort of going, like trying to understand, like, what are the features, what are the vulnerabilities, what things can we take advantage of and target. So do watch this space. I think there's a lot going on in this area, because I think there are some patients, there's a likelihood that our existing therapies are curing probably 20 to 30% of our patients. But we also have patients who have this functional cure for many, many years. And what would be nice to understand is is there a way, are there tests that we can do to see whether in those patients, maybe there isn't a CPC, maybe they got rid of their morsels with the first or second therapy. So how can we measure that? Is there a way to measure the CPC? And in doing so, would that allow us to predict how a patient's lymphoma will behave in time? So I think that, our therapies are getting really good, but I think that we also know that we are still underserving a proportion of our patients. And we think that if we can find out the personality of these CPC morsels, we'll be able to get therapies to target them.
Great, thanks. Yeah, it's very exciting to see that see a path forward. It might be a good time here to put up the second poll, which talks about what improvements or changes the audience would hope to see over the next 3 to 5 years. I think after Jessica's inspiring discussion of where some of the exciting science is, it'd be interesting to see what people think, what they're hoping to see over the next few years. And while we give you a minute to look at that, Paul, any thoughts on that? I saw like a lot of head nodding, like, wow.
Yes. I mean, yeah, just looking at the poll, I mean, they all sound great. But I mean, this idea of tailored medicine is very exciting to me. And just hearing you talk, Jessica, about the kind of way in, if you like, through the Achilles heel, or, you know, just your very descriptive way of explaining to lay people, I guess, how these systems work, and the lymphoma spreads. Yeah, it's very exciting to see there are people actively looking for tailored approaches to individual patients, because we're all so different. I mean, in the Facebook group that I co-run, co-moderate, there are like 12,000 of us, with such different stories around the world. And what might be great for me might be terrible for someone else, and vice versa. And if there is a blood test, which is also on the list, on the poll there, that gives me a peace of mind for a certain number of years, that would be incredible. I mean, just being able to plan, because it's really hard to kind of put into words how follicular lymphoma, although it is slow growing for a lot of us and maybe not as acute as some other cancers, the mental health implications are huge. I'm a therapist, like it's a big deal, and having tailored treatments and having a bit more control over where our life is headed, and not being constantly plagued with anxiety and uncertainty is massive, I think, for many of us as we head towards a cure.
Yeah, I think that message resonates in our previous webinars as well. The viewers really resonate with hearing someone like you go through that and go that they're not alone in these feelings.
Mm-hmm.
So yeah, people would like more effective targeted therapies and a blood test, I think, as Paul, you mentioned, to reduce anxiety, and they'll be able to tailor therapies. So all goals that we are actively, the field is actively moving towards, and that we are trying to support. So that brings me, Jessica, to another whole area that we haven't really touched on, as we focus on the follicular lymphoma cell. And what we learned is that it's not so simple. It's part of the immune system. And we talked about T cells killing cells, but there's the tumor microenvironment where a lot of the immune response actually supports and helps the follicular lymphoma grow, or the follicular lymphoma has to learn how to evade the immune system. So an impossible task would be to ask you in about 2 minutes to summarize where we are with tumor microenvironment, and how that might lead to understanding and treatments that might help us add to the benefit we already have. I'll give you 5.
Oh, thank you. That's very generous. Absolutely. I mean, when we think of these lymphomas, we don't think of them in isolation. I mean, they behave pretty much based on the company they keep. And so the company they keep are these kind of their immune cells that are surrounding it. And they're great at, subverting and persuading the immune cells that they don't need to get rid of them, that they're not the baddies, right? So, and this is the way I kind of always trying to explain it to my son, because he's always like, well, how do they do that? I was like, I don't know, the cancers are very clever. So, but I think that we're beginning to understand a little bit more about the company that the lymphoma keeps, this microenvironment, these immune cells that surround it. And I think that one of the reasons that I think that therapies that are approved are very effective in follicular lymphoma is because they also not just targeting the lymphoma cells, but they also do target the microenvironment as well. And what we've learned, I think, and I think Ari Melnick showed this really well in this symposium, is that the genetic alterations that the cancers or these lymphomas have, they're not just there to kind of make the lymphoma a lymphoma, but they're also there to try and manipulate the microenvironment, to manipulate the immune cells so that they don't target the lymphoma and get rid of it. So, and we saw some data, not necessarily in follicular, but we saw in diffuse large B cell that actually every patient's sort of aggressive lymphoma has slightly different microenvironment. So that's a little bit challenging when you think about every patient's lymphoma is different. But if also the company that it keeps, the microenvironment, is also a little bit different. So we need to think a little bit differently on how to manipulate the microenvironment to do our bidding so that it gets rid of the lymphomas. So I think that, where we are is that we need to try and understand not just the lymphoma, but the microenvironment. So a lot of the studies that are ongoing. So if we roll the clock back about 15, 20 years ago, we were so focused on, we need to understand the cancer cell, right? So, but now what we're doing is actually we need to understand the cancer cell and the company it keeps, because actually we need to have therapies that target both. And it's very clear that in follicular lymphoma, the microenvironment is very important for supporting and keeping the lymphoma cells alive. And I think that that's why, single therapies, monotherapies very rarely work in follicular lymphoma, that we find it's the combination of things. So being able to target multiple vulnerabilities. So rather than just focusing using one therapy to target one thing, if you have combined therapies, then it allows you to target multiple things that are multiple vulnerabilities of the tumor, but also of the microenvironment as well. So I think this field is still a little bit nascent. I think that we've probably come a little bit late to maybe a little bit later to the game compared to solid tumors, where it was established quite a long time ago that the microenvironment is, a bad player. And so I think that, I think we're making progress, but I think that that there's some, for example, Ari presented some really interesting clinical trials that are developing in Cornell, where they are using certain therapies to manipulate the microenvironment, so to make the microenvironment a little bit more conducive, and then they come in with a second therapy later on afterwards when the microenvironment is a little bit, better, improved, to then target the tumor cells. So they're very thinking of very innovative ways of targeting the cancer and sort of reprogramming the microenvironment to do what we want it to do. Hopefully,
it's an amazingly complicated system, is what we're learning, and as much as we learn, there's always new things to attack and new ways to attack it, and so it is really fascinating. So we talked a lot about, this really fascinating biology and new treatments. I know you were interested in some real world data, meaning like what happens to patients, maybe not in the clinical trials, and some work. I wonder if you comment on some of the things that are coming out from studying what happens to patients who are in these Facebook groups, that like the one Paul runs, and what we can learn from this heterogeneous system where everyone's different.
Yeah, I mean, Mitch, I think that, you're absolutely right. I think one of the challenges of clinical trials is that they will collect information on patients for a number of years, but that's a set number of years. But we know that patients with follicular lymphoma are living for many years longer, and we need to know what happens to them in 5 years and 10 years. And the only way that we can really start to capture that is through these sort of what we call real-world data sets or real-world studies, where we're able to look at a population-based level and to understand, what therapies people are having, what side effects, what complications they're having over a long period of time. So it was nice to see some data presented by Dr. Kim Linton, who works at Christie's in Manchester in England, who has basically looked at some very large population-based data in England. So looking at over 17,000 patients with follicular lymphoma, and they were able to look at a number of different things. So one is to look to see how patients with follicular lymphoma, how they're surviving. So one of the things that was really important to see was that they demonstrated that depending on the region of England you lived in, you had slightly different survival outcomes. So areas where there is more social deprivation, patients in those areas seem to have lower survival than patients in areas that had, that are obviously more well off or in that sense. And I think what was really interesting also was that when they looked at for patients that unfortunately didn't survive, they looked to see what was the cause, what was the reason why the patients didn't survive. And what was really interesting was that many of them didn't survive, not because of the lymphoma, but actually because of many other things that are going on. And so it sort of this data kind of made me really think about, if patients with follicular lymphoma are dying of unrelated causes, I think it really underlies the importance of really balancing effective treatments with toxicities from therapies, quality of life. So really importance of selecting the right therapy, especially for older patients who have other comorbidities, other medical conditions, because if they are dying because of toxicities, then we really need to take that into account. So not to just focus on picking effective treatment, but we have to pick effective treatments with minimal toxicity. And so I think that was really the sort of the take-home message from that presentation was, outcomes are good, but there are other factors that we need to think about as well. Areas of, deprivation seems to be that really resonated from that presentation. And the other is that if patients are dying of unrelated causes, we have to be mightily careful the selection of therapies, because we don't want to be causing harm to our patients by selecting a very effective therapy, but actually a therapy that's quite toxic and that can cause complications in later life.
Yeah, I think well put. And I think we always worry when we're wiping out B cells and affecting T cells, what we're doing to the immune system, risk of infection. This does bring out, there have been a number of questions in the chat about two areas I just wanted to touch on. One is second cancer. Some people have cancer before the diagnosis, some people after, some at the same time. Could be incidental, could be coincidence, because cancer is common. So that's one. And the second area is a couple of people asked about genetic predisposition, the certain families that it might run in. But what do we know about genetic predisposition? And separately, or maybe related, what do we know about risk of other cancers, either coexisting or did we cause them with our treatment and that sort of thing?
Yeah, I think it's one of the questions that a lot of my patients ask when they're first diagnosed with follicular. They always ask, is this something I did to myself? Is it something like diet or, and I usually say it's nothing that you've done. So there isn't a lot of data that suggests that there is a genetic predisposition to getting follicular lymphoma. So that's the first point. The other, of course, is that we do know that after, very long experience of using certain therapies, that certain types of therapies, certain types of chemotherapies does increase the risk of secondary cancers. And perhaps that's also one of the reasons why we know, for example, stem cell transplants, for example, that there is a risk, a small risk, but not a risk that should still be considered of secondary cancers. And this is why I think that particularly as we get more therapies, we really need to think about long-term toxicity. So, and this is where, real-world data is also really important, because we want to be able to roll the clock, 10 years forward to see what long-term risks there may be of any of these new therapies. And in terms of, are there ways to predict? We have the difficulty is we don't have any way of predicting whether certain patients are at higher risk or not. And I think that the challenge sometimes, as you say, Mitch, is that sometimes people have some cancers diagnosed before they're follicular, some after, and we don't really have great ways of working out whether it's something that we gave to the patients that might have increased their risk in terms of therapies that we gave for their follicular lymphoma. There is some evidence of certain therapies that may increase that risk, and I think we have to be very mindful of that. And that's why I'm always very cautious, even with new therapies. I'm excited by them, but also I think about, are there any signals that tell me that longer term that there may be other, side effects that may arise?
I mean, I guess the other thing is we do know that people with autoimmune disorders have a higher incidence of lymphoma, not only follicular lymphoma. And it's a disease of B cells, autoimmune cells. And so, there's sometimes it could be that the patient's immune system is a little bit out of whack to begin with, leading them to lymphoma, but also maybe other cancers. So
yeah, you're absolutely right. I think that we are starting to learn a little bit more about the patient's immune system. I think that because, when I mean the immune system, it's the immune system even before we give them any treatment. So there's something about the lymphoma that makes you a little bit more susceptible to infections. And then, of course, if there are some therapies we know increases the risk, so we know, for example, with bispecific antibodies and CAR T cells, that there is an increased risk of infections. later infections after the treatment. So I think that this is why we need to be really cautious with these therapies. Also, as much as they're very effective, we need to think about following patients for a period of time so that we can understand the risks associated with it and how to reduce those risks, and that might mean changing therapy, for example. And this also speaks to a question. I think I saw a question pop up on the screen about whether we still need maintenance therapy after initial therapy. I think it's a great question. I would love to know the answer to it, but the answer is I don't know the answer to it yet. I mean, we have a clinical trial in the UK that I hope will allow us to answer this question. And I think that the sort of take home, I think, is that more is not necessarily better, sometimes. So I think that sometimes, having therapy for a long period of time may not necessarily improve things. That sometimes a shorter course of therapy may be better. And this is where the clinical trials will be very important to allow us understand whether we can curtail certain treatment or whether we need to continue with therapies like maintenance, for example.
And just to jump in there quickly, if I may, that I've wrestled over whether to do it or not, but I am due to start maintenance from September, which was recommended to me, and it was, as I say, a bit of a tortured decision because I don't want to be on treatment for any longer than I have to, but I want to maintain remission for as long as possible as well. But I've been lucky that my remission came after 4 rounds of BNR, and my immune system is bouncing back, so I feel relatively confident going into, after a few months break, back into maintenance. I'd love not to have to do it. I'd love for you, Jessica, to be clearer, on doctors in general, to be clearer on whether maintenance is the right thing or not. At the minute, it's often given back to us to say, this is the option. Do you want to take it or not? And that's quite hard for us to manage sometimes. I feel quite confident that I'm doing the right thing, but some others don't.
All right, I apologize anyone who's back on for the Zoom issues, and we're gonna, I think, have to sign off. But I do appreciate everyone's attendance. We will try to figure out how to get some of the additional questions answered along the way. So if you check our website, we'll work on a way to do that. And I do want to thank our sponsors of this entire series. And I'm not sure if the slide is up, but we do have our sponsors, and we appreciate their support. And with that, we will try to get back in touch with everyone. Oh, there you go. So those are our thank you slides, and we will be in touch. Please check our website for further information. Thank you.
Thank you.
Thank you, everyone.